I think it's time now to start. Ich darf Sie ganz herzlich begrüßen zu dieser Sitzung. Don't worry, we will speak English, no problem. So welcome. For this educational session, we will mainly talk about infected wounds. And first of all, I would like to thank Convatec giving us the possibility sharing some really interesting data. Housekeeping. You all have blue abstract books where you also find the evaluation forms and the question cards. Please be so kind and fill out the evaluation forms. This makes everything better, and give it to the staff at the end of the session. Questions, it's very important that we discuss a lot. So we are here looking forward to your questions, to learn from you. You can write down your questions on the question card you find in your program book, or you can use the microphone, but I think it makes sense to have a question and answer session at the end after all the presentations. What can you expect? Hopefully a lot. First of all, you all handle in your practice infected wounds, and you know how difficult it is sometimes to diagnose that. But without the right diagnosis, it doesn't mean you're doing the right. So this is an important fact. Then you have the diagnosis and you must make a choice. And the choice should be based, of course, on evidence. Let's take now, you have got all the right evidences in your mind, you did the right choice, and then the patient is happy, the problem is fine, but what about costs? At the end of the day, administration comes to you and says, this was not cost effective. You overdid it. It's just not possible that you treat these patients in this way. So everything goes together for a good routine. And this is exactly what we would like to present and share and discuss with you, all that topics that at the end of the day, you are happy, the patient is happy, and the administration is happy. And with that, I would like to start with Professor Christina Lindholm, and she will talk about wound infection, consequences for the patients, and costs for healthcare. Please, Christina, we are looking forward.
Thank you very much. Thank you, Mr. Chair. Ladies and gentlemen, thank you for coming to this session in such numbers. I will introduce this session a little bit by having a broad perspective on the question about wound infections. If we look at healthcare costs in general, there are quite challenges for all of us in the future as taxpayers. The World Bank has estimated that expenditure for the healthcare is expected to rise from 8% in 2000 to 14% in 2030. And this is according to the general gross domestic product. In Sweden we call it bruttonationalprodukten. Can you say that? Anyhow, we will have a problem in the future. And this is due to the aging population, the demographic winter that is approaching. There will also be more chronic diseases once people are aging, and more advanced medical methods will be available. What about prevalence of chronic wounds? Quite recently, we saw some very interesting figures, as a matter of fact. Between 20 and 50% in hospitals of the patients have wounds. 55 to 60% are chronic wounds. The annual incidence in Europe of chronic wounds is now estimated to be around 4 million. That is more than cancer, diabetes, and cerebrovascular diseases. So that's quite a lot. What about prevalence of post-operative wound infections? The prevalence varies grossly between different studies, different centers, and is very much depending on how long time you follow up the patients. If you follow them up for a longer time, you will have higher figures. One study with deep wound infections, sternotomy after coronary artery bypass surgery, showed that wound infection, post-operative wound infection, increased the days for hospital stay significantly, and the survival was less likely, also significantly. What about prevalence of infection in chronic wounds? Very recently, there was a systematic review published, including 15 studies with 1,056 wounds. The prevalence was estimated to 53% in these studies altogether. But we have the clinical dilemma: is it really a wound infection in chronic wounds, or is it heavy colonization, contamination, colonization, heavy critical colonization, biofilm, you know, all these things, or is it a true infection? It's not possible to judge that only by lab tests. What are the costs for wound infection? It delays hospital stay with a mean of 4 days. Cost approximately 700 euros per day. If we sum that up, it will end up around 2,800 euros per patient. Another study shows that cost of care amounts to 24,410 pounds compared to non-infection. This was post-operative wounds, and the non-infected wounds cost 7,210 pounds. That's a comparison. The cost for an average hospital for wound infections is estimated to be 2 million euro per year. We can do a lot of care, can't we, and treatments for that sum of money. What is the cost then? Why is it so costly? Prolonged hospital stay and readmission of the patients, antibiotics, risk of antibiotic resistance and what that means, of isolation of patients and so on, frequent dressing changes, and reoperation and surgical revisions. What about costs for quality of life, reduced quality of life, the so-called intangible costs? A wound infection causes the patient lots of suffering, pain, heavy exudation, malodor in some ways, sometimes frequent dressing changes, sometimes surgery. General condition deteriorates. What about wound infection and antibiotics in chronic wounds? Here I have some figures from Sweden, and I don't think it differs very much if we look at your countries. This was a survey in Sweden, and it was done regularly between 2005 and 2008. 208 primary care clinics were included, and 786 soft tissue wounds and infections were included. 79% were on antibiotics at that time. And we could see an increase at 2008, which was very sad, of course. Overuse of antibiotics adds costs. And I have very recent figures from May this year. 59% of patients with leg ulcers are on antibiotics, if we look now and 6 months back in time. And this is from the Swedish National Register of Wounds, May 2012. Why do we give so much antibiotics to patients with chronic wounds? Is the diagnosis based on results from lab tests? Yes, then it's very easy to prescribe antibiotics by routine. We did a study in 2006 and also later in 2008 and 2009. These are the results when we look at the heavy growth of bacteria found in chronic wounds. 3+ is a heavy burden, and 410 wounds were surveyed in hospitals and community-based elderly care. So you could see quite a lot of the Staph aureus, the proteus, KNS, Enterobacter, Enterococci, and the Pseudomonas were abundantly growing in these lab tests, and only 5% of them had topical antiseptic treatment. That is very little. This was due to restrictions in this area of Sweden at this time. We weren't allowed almost to prescribe antiseptic dressings for the patients. which would have been beneficial for many of these patients, so that they don't turn over into an infection. Antibiotic resistance adds cost. It's a bigger threat to humanity than global warming. It's Otto Kars, who is the chief of the antibiotic control in Sweden, who has said that antibiotic resistance is a bigger threat to humanity than global warming. It's also a personal disaster. This is how the map looked like until quite recently. I now heard that England is free, is green. David told me England is green. That means that there are not so many Staph aureus which are resistant to methicillin anymore. But you can see in some countries it's quite a problem. Over 50% of all Staph aureus are resistant to methicillin due to overuse of antibiotics. MRSA increases admission lengths and costs significantly. And a PhD student of mine, Helene Andersson, has published a study where she had interviewed patients with MRSA. And one said, "I was really in a panic. I felt like a leaper." Another said, "I felt I was a walking focus of infection and that I was very dangerous." And another said, "And he, the doctor, told me, and he scared the life out of me. I will not shake your hand. You cannot travel by bus. You are not allowed to use the underground, and you should not have anything to do with other people." This is quite frightening, isn't it? You can imagine any one of you who gets this message, isolation from life completely. That's scary, isn't it? How patients can experience it, and how the knowledge of some staff still is not so high. But can we reduce the incidence of wound infections and costs for healthcare and patients? Yes, I think we can do a lot. Everyone in this room, we can all do quite a lot. By adherence to infection control protocols, by restrictive use of antibiotics, by improving the patient's general condition, and to reduce heavy bioburden locally, topically in the wound. Infection control, I took this picture quite recently, so it's not an old picture or anything. This is in one of the special clinics where I used to visit. The hands, this was a beta hemolytic streptococcus infected patient, group A, so it was not so good to have the bare hands, was it? Wow. And what about infection control? I mean, the prevention of spread of bacteria, hand hygiene, disinfection, absolutely the most important. Optimal hygiene at dressing changes. Plastic apron, gloves, no rings, bracelets, wrist watches. We have done a number of studies both in Sweden and in Iceland, as a matter of fact. This is just from one of them. And here we should have 100% adherence. It should be 100% in all this. I will not read all this. But what we can see as a trend in all these studies is that more people disinfect their hands after the dressing change than before. So who is we? Who are we protecting, ourselves or the patients? And the gloves and the plastic aprons and so on. We trained the staff quite intensely after this first study, and we put up posters on all wards. In this ward, we care for the patients by acting according to strict hospital hygiene principles and guidelines. We show the respect for you as a patient by wearing short-sleeved clothes, changed daily, having short-cut nails and long hair worn up, not wearing rings or wristwatches, and carefully disinfecting our hands before and after patient-related procedures. If we forget, please remind us. You can see the point. That was very good to activate the patients and the relative family. That was very successful, and when we did the study a year later, we could see significant changes in all these parameters. So we can do a lot. What about reduction of the heavy bioburden, the last point? Wound cleansing is, of course, essential for what we to reduce the bioburden. On the picture to the left, it's a picture from Peru in the 1700-something. There they had wound lickers employed, people who were employed to lick the wounds with their tongues. And that's not really what I don't think we can find this kind of people in today. were willing to do that. But anyhow, it made a lot of sense, because the tongue acts like a brush for the bioburden, you see, biofilm removal. Saliva was rinsing the wounds, and there were growth factors in the saliva, as it is with dogs who are licking their wounds, and all animals and so. So there was something in it, even if it is not practically applicable in our care. Another way to reduce heavy bioburden is by debridement, of course. And reduction of the heavy bioburden is also effective by antiseptic dressings. And I think we are changing the paradigm right now. We have been very careful with antiseptics for a while. Now the paradigm shift is coming, as I feel it. We can be more liberal towards these more modern antiseptic dressings. For example, silver dressings. But we have to keep those stringent indications and for limited periods of time. And you will find that International Wounds Boot, this excellent silver document that is released tomorrow at this Congress. A group led by David Lieber has been working with this document, and I think it really answers all questions that we need to know. So it's called Appropriate Use of Silver Dressings in Wounds. It's really a useful document. This is a patient, 46 years old, with multiple sclerosis. I took the picture about a month ago and has followed him. We put Aquacel AG in the ropes under the undermined edges of the patient's wound, and then we covered the wound with an Aquacel hydrofiber with silver dressing. And there were some dramatic improvements, both according to malodor and exudation. So, conclusions. Many wound infections can be avoided. Patients' well-being can be improved. Less antibiotics can be used. Risk for antibiotic resistance can be minimized. Major cost savings for healthcare can be obtained if we do all these things. And adherence to infection control guidelines. Careful cleansing and debridement, and topical antiseptics when needed, when there is a critical colonization or even an infection in the wound. So I would like to thank you by that and give the word on to Professor David Lieber. Thank you very much.
Thanks, Christina, for that wonderful and excellent presentation. I mean, the question is, perhaps you opened a new job profile in our excellency in wound healing field. Okay, next we have Professor David Lieber. He is Professor of Surgery, coming from Cardiff University and Imperial College in London, and he will talk about treating wounds at risk of infection. Please, David.
Thank you, Robert. First, Christina, thanks for promoting this. Go and get one. They're all free. And I have to say, Christina, I'm prepared to lick your wounds anytime. Look, a lot of what I'm going to say, you know, and I'm going to go over it very easily and quickly. When you look at infection, really the key is thinking about underlying pathology. If you ignore that, you never get on top of the bioburden. Acute wounds are the ones I used to spend a lot of time with. They're at risk of infection, and today is not a time to talk about that. Chronic wounds too, and they remain chronic because there's an underlying pathology. And when you've got this big bacterial bioburden, there's an increased metabolic load. There's a lot more activity in the wound. They don't heal. But the signs of acute inflammation, this is an undergraduate slide, you all know that, they're very easy to pick up. When a wound's acutely infected, it's easy. But what about a chronic wound? You know, we have to start relying on Delphi techniques for chronic infection. You know, how many of you would agree with this? This is a donor site, 6 weeks old. It's not healing. Why? Probably because it's infected. A diabetic foot. He's got good arterial inflow, but he still has a dead toe, and he still has the diabetic ulcer. Would you give that patient antibiotics? Because I wouldn't. We don't even know how to count the bioburden. What technique would you use to swab your wounds? Do you use a zigzag technique? Do you press the ulcer so hard with the swab the patient squeaks? So you get the deep bacteria out. They're the ones that you want to manage. If a microbiologist gives you an antibiogram, it's very hard to resist giving antibiotics. So they don't give you an antibiogram. And biopsies, forget it. Patients hate them. And ethics committees aren't keen either. In the UK, they said to me, well, okay, how should we be treating infection in venous ulcers? How many of you would agree with the things that we said? Never do routine swabs. Make sure it's transported well. Don't ask for antimyograms unless you're really looking for a pseudomonas or a beta hemolytic strep that you seriously intend to treat with an antibiotic. Use your local formulary, but think antiseptics first. And we have this other concept which a lot of people struggle with. You can call it pro-infection if you want, pre-infection, but I think colonization that's critical is now here to stay. But wouldn't it be nice to have a diagnostic for it? Because that would push you, perhaps a little bit earlier, to use an antiseptic. But none of you would disagree, I hope, with this list. Antibiotics still have a role to save people's lives even. And all of these conditions, you would use an antibiotic. You wouldn't delay, would you? I wouldn't. Whilst you're reading that, let me introduce you to Alexander Fleming. He worked at St. Mary's Imperial College, as I do, and they're all completely mad at St. Mary's. You can tell that by the staring eyes. And this is his first patient, PC Alexander, and they treated him for bacteremia with Staphylococcus with penicillin, the first ever. Recycled it from his urine, and he did rally, and then they ran out of penicillin, and sadly he relapsed and died. But surely Alexander Fleming is saying from 60 years ago, here's a new set of drugs, antibiotics, look after them, or you'll be sorry. And we haven't. Look at the problems we've got. Extended spectrum beta-lactamases, which mean now if you can't use quinolones anymore for UTIs. Glycopeptide-resistant enterococci in ventilator-associated pneumonia. And all these you've already heard. And it's all our fault. Antibiotic misuse. We've got to stop doing it. And there's another cogent thing. There's no more antibiotics. This is it now. We've extended it. You've heard of linezolid, you've heard of tigecycline and dori. Brilliant antibiotics, broad spectrum, expensive, safe, non-toxic, but there's no more coming. Now the industry will say, we'd rather produce Viagra and statins. We make more money. Why do we want to bother doing antibiotics? It costs $1 billion US to produce a new antibiotic. What's the point? Think about it. Let's think antiseptics. They've been around a long time. I shared this nice document looking at surgical site infection, and one of the interesting things we said at the end, there's a lot of research opportunities here, looking at antiseptics, incised drapes, intracavity wound lavage, sutures, in prevention, dressings, and it goes on. And they've really been overlooked, I think, the antiseptics, and there's lots of good new antiseptics around. I mean, there's good old Chlorhex and Povidone we've had for years. We know they're good. We know they're effective. We know there's polyhexamethylene biguanide, which is a new antiseptic to us in the UK. It's been around here in Germany for a couple of decades. Triclosan and silver. Not sure about these. Oh, by the way, this is Lord Lister on his ward round. The junior staff for once have turned up on time. Clinical use of antibiotics. Well, we use them for hand washing and skin prep. Nobody would argue with that. And there's no antimicrobial resistance. I'll come back to that. But antiseptic got this bad name because of the risk of toxicity. And those of you who know me know I've been saying to this society for years, beware of antiseptics in the wrong types and the wrong concentrations, because they are toxic to tissues. The hypochlorites should never, in my view, be used as a routine, because they are toxic to tissues. And I'm not going to go over work that's 20 or 30 years old. Some of you who know me will remember all that. But the risk of antiseptics has taken another twang. There's a particular microbiologist in Christina's country who is saying, well, you know, antiseptics are a concern to me because they might bring out a highly resistant organism. And there is this theoretical risk that that resistance could be plasmid carried on, and that you may have even resistance to antibiotics. Well, there's an EU document which has looked at this carefully with regard to triclosan in particular, and they find there is no evidence of getting this resistance with antiseptics. So let's rethink them a little bit. And remember that antiseptics damage the bacterial organism from everywhere. They hit the nucleus with the DNA, they hit the efflux pumps and the cell walls. Antibiotics are much more specific. So the chance for a mutation that's plasmid transmitted is high. We've got to stop using so many antibiotics. And here's another problem. I'm still concerned that a lot of you think you can see biofilms. You can't. But, you know, this is a place for research. And the one Frenchman who I really admire is Louis Pasteur, who said, if you're going to do research, keep your mind wide open. I love that. Tell your students that, and they might come and play with antiseptics and so on. But the dentists are way ahead of biofilms. They recognized 30 years ago that if you brush off this biofilm, then you don't get gingival disease. Oh, this is from the blocked drain next door. That lovely smell, that's biofilm. Rubbery, horrible stuff. And remember, all bugs can produce this glycocalyx, the mucopolysaccharide, which they can sit in and be absolutely resistant to host defenses and antiseptics and antibiotics. They talk to each other by, who comes up with these words, I don't know, by committee is a posh word for it now, quorum sensing. But they are there, and when the conditions are right, they go planktonic. And they're the only bugs you culture normally. The problem with these biofilms is they're probably more prevalent than we think. This is a woman who's had a large lumpectomy for cancer and a sentinel node biopsy. She's had a suture removed at the 10th day. There's no pus, there's no inflammation, no smell, and a swab from the wound shows no growth. Is that an acute biofilm preventing growth? Huge areas for research, and we're looking now for a diagnostic for maybe a biofilm in that. You don't know there's a biofilm there. That could be host response. But we do need that diagnostic. But remember, whilst they're on the wound surface, they're still promoting all the white cells to produce and overproduce proteinases, reactive oxygen species, nitric oxide. So it's a pro-inflammatory effect. Bad news for wounds. But if you want to measure biofilms, this is what we got to do. Big stuff. Confocal microscopy, PCR. But there will be a diagnostic. One day you'll be able to take off a dressing, spray it with some, I don't know what, serum rhubarb, and it'll go purple. It's a biofilm. And that says, come and get me. Come and take me off. And there are brushes appearing, as you know. But they're everywhere. This is an endotracheal tube, and colleagues in Cardiff have shown that at 3 or 4 hours there is biofilm on the endo side of endotracheal tubes. Are you surprised we get ventilator-associated pneumonia? Because I'm not. So antiseptic dressings might reduce this bioburden. They might help with debridement. They might help reduce the risk of biofilms, maybe as a barrier. And of course, if that works, it would be good. But which antiseptic? For silver to work, it has to be ionic. It's been around a long time without resistance. The problems are, how do you measure response? And there's this confusion, zones of inhibition, parts per million. You need to sort of get your head around some of these things. It's not all that easy. Should the silver be nanocrystalline, producing a large amount of silver to the wound surface and maybe used for 2 weeks max? Or should it be in a dressing, like we've already seen, Aquacel, where there's a secondary effect that's handling exudate? So there's 2 things in the dressing. All these things really could do with a bit of research to sort it out. But I personally think that speed of kill is important, bearing in mind how quickly bugs can divide. And there's this lovely new thing now, a 3-log reduction. If you don't really know what that means, a 3-log reduction means you're killing 99.9% of the bacteria present. That's pretty good. And where should you use antiseptics? Well, maybe quite early on, but right through to infection. Even if there's systemic infection, you could still control it locally with antiseptics. Here's one of my favorite men, Paul Ehrlich. He even got his face on a banknote. That's got to be good. But this is Deutschmark. It's gone down the drain now, but there we are, it's euros. Perhaps they'll come back, who knows? Who knows? But he had this concept of rapid kill and the magic bullet. It works. Evidence. David Sackett, the guru. And he's saying, use the best evidence available. But also, look at your expertise, your experience. Look at what the patient and the carers think before you start just shoving into health economics level 1 evidence. I'm a little concerned about level 1 evidence because it only looks at this. And I'd love to have met Archie Cochrane before he died because I'm sure he wouldn't be so focused. Maybe I'm wrong, but I think to say the only evidence we can use is level 1. In our field of wound healing, there is very little level 1 evidence. So you've got to look at what else there is. And I really think we must be careful about this anarchy about level 1 evidence. Is it going to come? Who knows? It's expensive to get it. But the Cochrane people in wound care are saying more research is needed. That doesn't help you write a guideline for your health institution. And you've got to write guidelines. And they're saying debridement might not work. How many workshops are there here this week on debridement? If it doesn't work, why are we teaching people to do it? Yeah? Do we need an RCT to show if parachutes work? What about topical negative pressure? It's the same thing. We know it works. And I don't think we're going to get an RCT evidence to prove that. But the Cochrane is right. I mean, it's standing on the shoulders of the giants who've done the research. And there are some things, these two Cochrane reviews looking at silver, they've got a huge database of silver dressings to read. They've elevated the discussion, and I think people are much more aware of what is bad sort of trial work, and they've highlighted these differences. But they only look at studies that are RCTs, often without one of us involving in the study, which I think is a shame because we can help modulate what's said. And I don't sure that meta-analysis always works with the heterogeneity of wounds we see. And there are other meta-analyses which have been pro-silver. These two, for instance, systematic review and meta-analysis, quality of life improved. Strong evidence for wound healing and wound size reduction. Quality of life improvement. But maybe if we do some more, we could use surrogates of odor, length of wear time, and so on. Then the Vulcan study came, one of the best studies we've ever had in wound care. It's well randomized, it's well powered, asked a lot of things, and it was really a very good study, I think, with one fundamental and very big flaw. It asked, do silver dressings heal wounds? Well, of course they don't. They control the infection on open wounds. So looking at this, 12 weeks of a silver dressing without any microbiology at all, for me, rather spoilt that study. And it had a great opportunity that it missed. I'm coming near the end, Chairman. Silver dressings, performance and toxicity then, they do rapidly reduce bioburden. I think there's good evidence of that. Some of the dressings have a rapid and sustained action. Probably you shouldn't use them beyond 2 to 3 weeks. Maybe the less silver-containing dressings could be used for barrier or act against biofilms. But the stuff about silver toxicity is not, in my view, again, very impressive. I don't think you need to seriously worry about silver toxicity. And Christine always likes me to use this as a final slide in my talks. When I sit on the throne at home, I like to read Harry Potter. And he seems to have got it sorted out, Mr. Chairman, so I'll leave you with that thought. Thank you very much.
David, thanks a lot for this really wonderful and important lecture. And now Henry will present you wound dressings, evidence to meet the challenge of infection. Dr. James is the medical director of Convatec. Please, Henry.
Thank you, Dr. Stronghold. I will start my intervention saying that, as you have heard, Professor Lindholm gave us a very good idea of what it would be if we don't pay attention the economic burden imposed by the treatment and total cost of care. And Professor Lieber just laid out the basis on what is I would consider the importance of dressings with antimicrobials in the management of infected wounds. So let me go a little bit further in this reasoning, just to try to make a link between these two things with the evidence that we have currently. So whether it is new or is going to be, or the evidence that is already published or about to be published, it's how we see, how we read, how we go through this, and what are the benefits of the analysis that we can do from this evidence and how we get them. So in the current healthcare climate, therapies must demonstrate value on top of quality, safety, and efficacy. And that is, it's something that every one of us dealing with healthcare are living every day. However, true value in healthcare cannot be determined by the cost of the product alone. So we need, when choosing, for example, an antimicrobial dressing, consider how the clinical evidence is going to affect the cost of total care and our ability to prove that is the good way to go. So we need to consider, and that's a little bit of challenging that we need to get into, is consider 3 different categorical questions when analyzing evidence. The first one is, can it work? So that would be wound-centered outcomes, controlled trials on efficacy and safety. The second one would be, does it work? We would be patient-centered outcomes about quality of life, for example. And the third one is, it is worth it. So it is cost effectiveness. Patient-centered outcomes that they relate to direct and indirect cost. So let me introduce you to go through 3 different cases on how good clinical evidence lead to good value, because it's about providing value. The first one is in acute wound management, and is a study that is about to be published, that has been performed in the Netherlands, about the treatment of patients with partial thickness burns with, obviously, silver dressings. They randomized 100 patients, 50 in each group, and you can see that in both groups, we had equivalent causes of burns, and the groups were also very similar from a demographics point of view. The body areas treated were equivalent. The burn depth was assessed by what they use and call laser Doppler imaging, which is a technique which allows to determine if the wound will heal within a predetermined period of time. And patients that they consider through this technique that they will be healed within 21 days were included in the study. And all the dressings were used following manufacturers' instructions. As I said, from a demographic point of view, there were no differences on the treatment of the surface of the body that was burned, and the values on this laser Doppler was also in the same range. So the outcomes were, they didn't find, difference in healing, no difference in infection outcomes either. We found that there was a bioburden with more Staphylococcus aureus in the nanocrystalline with the silver group. But, however, there were significant difference in health economic outcomes. So what is important here is considering the total cost of care. So you can see that there were obviously a lower number of dressing applications, a number of dressing use, a number of dressing interventions, and the total time spent was significantly lower in the group with Aquacel AG. So we were talking about value, but we can see that it's important when we consider patient outcomes. There was less pain with Aquacel Silver and increased comfort. And you know that I think in not only the UK, but in other countries, the quality of the care that we are providing and the answer or the feedback that the patients are providing might have an influence in the budgets that hospitals and trusts might get from the Department of Health. So this is important too to take in consideration. So from this perspective, so we can say that although healing time and bacterial control were similar in both dressings, in the group with Aquacel Silver, there were a requirement for fewer dressing changes, significantly less dressing material, significantly less clinician's time, and the patient outcomes were better from a quality of life perspective. So this is a way of providing evidence on effectiveness and better value, because we're saying we have the same kind of result from a clinical perspective, but we are, from a global cost perspective, spending less. The second case is not related specifically with silver, but is related with decreasing risk in patients with undergoing surgical interventions in orthopedics. This is an article that has been published very recently in the Journal of Wound Care, and is a study that took in consideration 100 patients that benefit from total hip or total knee replacement. And it was conducted as an audit. The first 50 patients were treated as the only difference was the dressing that they were put on at the end of the surgery. And the other 50 were with a dressing with Aquacel, which is called Aquacel Surgical. There is a increasing risk, there is a trend towards knowing what is happening with wound dressings in surgical procedures. And in orthopedics, it's quite important to just make sure that the patients can go through very quickly and start rehabilitation. So the study looked at some specific measurements, which were wear time, the number of changes, the blistering rate, and the length of stay. If you look at the demographics, the two groups were similar. But when you look at the results, in the group with the traditional dressing, the rate of blistering was 20%, whereas was only 4% in the group with Aquacel Surgical. The wear time was 2 days in the traditional dressing group, but it was 7 days in the Aquacel Surgical group. And the number of dressing changes was 3 in the traditional dressing, and no changes on average on the Aquacel Surgical group. And these values were all statistically significant. Regarding the length of stay between the two groups, there was no statistical difference, but you can see that there is a concentration of the stay in the Aquacel Surgical group, meaning that we had patients in the other group that stayed for longer. We had 75 of patients that were discharged by day 4 in the group with Aquacel Surgical, and it took 6 days to get to the same number in the other group. So we can say that using the correct dressing might result in increased dressing wear time, reduce of blistering, reducing the risk of infection, because obviously blisters increase the risk of infection, and in the end might lead to increasing the cost of treating these patients, washout in surgery, or even loss of the prosthesis. Reduce the length of hospital stays. Having patients going in a very safe way to the hospital would mean that we will be able to treat more patients that are in a waiting list. And obviously, from a patient perspective, the early mobilization will end up in better outcomes as for the rehabilitation is related. So this is also a clear evidence that we can extract from this kind of studies related to effectiveness and value. The last one is an article that has been recently published where it's a case series. So we're taking every single possible evidence that we might find in the literature. It's a case series of treatment in chronic wounds, patients with very difficult to treat and very difficult wounds. And they present nine patients. And I just would like to present one case. It's a 63-year-old female with end-stage renal disease with an injury in the left lateral calf. So after injuring her leg, she was treated by her primary care physician, practitioner, for more or less 6 weeks with antibiotics, an antibiotic ointment, gauze, and a polyurethane film. The wound grew, became smelly, with active drainage, and was covered with a thick green tinted film. So you can imagine, it was not very good. This patient was seen by the authors, and it was changed to a different management regimen with a silver hydrofiber dressing under compression wrap, and the wound began to show improvement very quickly. In a few weeks, we had in the opposite, on the picture named B, how in just 3 weeks the wound has improved. The treatment was continued because the patient went into a kidney transplant stage, and because of this immunosuppressive therapy that she was receiving for that, the treatment was decided by the authors to continue on compression and Aquacel AG. The wound progressed to healing without further infection. So the interesting here is to just take in consideration that early diagnostics and management of infected chronic wounds with silver antimicrobial dressing help to effectively treat wound infection and, because of that, reducing total cost of care. So in summary, I would like to say that using management strategies backed up by sound clinical evidence can significantly improve the quality of care and health economy outcomes. And I would like to add to this that in the challenging environment we are from an economic perspective, we clinicians need to be bolder. We need to stop being, suffering the consequences of the decision of others, and making sure that we adapt and we take in consideration the evidence that we can collect, that we can create, to make sure that we provide sound business case to demonstrate that we are providing value while increasing or improving the quality of the care that we are providing. Thank you very much.